All right, let's dive into a topic you'll definitely see in your obstetrics posting and for sure on your exams: spontaneous abortion, or what's more commonly known as a miscarriage. Getting a solid grasp on this is absolutely crucial.
So what's the difference between a threatened and an inevitable miscarriage? Is it just the amount of bleeding? And what's this about the cervical os being open or closed? This is where students get tripped up all the time. But don't worry, by the end of this, you're going to have it all crystal clear.
Okay, take a look at this flowchart. This is basically our map for today. We're going to follow this left branch here, spontaneous miscarriage, and walk through each of these types one by one. This way, you'll see how they all connect and how to tell them apart.
So here's our game plan. We'll start with the basic definition, then get into the why, the causes. After that, we'll tackle the different clinical types, figure out diagnosis and management, and then we'll wrap it all up with a super quick, high-yield recap. Ready?
First things first. We need to be on the same page about what we're actually talking about. A precise definition is everything in medicine.
So, according to the WHO, a spontaneous abortion is the loss of a pregnancy when the fetus weighs 500 grams or less. Now, that weight roughly corresponds to about 22 weeks of gestation. You need to remember this cutoff: 500 grams or 22 weeks. It's a classic exam question.
And just how common is this? Well, it's estimated that 10 to 20% of all clinically recognized pregnancies end in miscarriage. That's huge. It means for every 10 pregnancies the doctor confirms, 1 or 2 will unfortunately end this way. So this is something you will encounter.
And timing is really key here. Look at these numbers. The vast majority, about 3/4, happen before the 16th week, and most of those happen in the first trimester, before 12 weeks. This tells you that those early weeks of development are just incredibly sensitive and critical.
So, the big question is why? What causes a miscarriage to happen? Well, the reasons, the etiology, can be quite varied, but there's a really clear pattern, and it all depends on when the loss occurs.
Just look at this chart. A full 50%, half of all early miscarriages are because of genetic problems with the fetus itself. That is by far the biggest piece of the pie. The other half is a mix of other things like hormonal imbalances, uterine structural problems, infections, and so on.
Now, this is a super important concept for your exams. Think of it this way. First trimester losses are usually a problem with the seed, the fetus itself, most often a genetic error. But second trimester losses, those are more often a problem with the soil, maternal factors, like a cervix that can't stay closed or a uterus with an abnormal shape.
Okay, let's get into the core clinical stuff. How will a patient actually present to you? This is where we need to break down the different types of miscarriages you need to be able to identify.
Okay, first up is a threatened miscarriage. The key idea here is that things have started to go wrong. There's bleeding, but the pregnancy might still be salvageable. It's a threat, a warning sign, but not the end of the road just yet.
Now, contrast that with an inevitable miscarriage. The name really says it all, doesn't it? Here, the process has gone too far. Things have progressed to a point where, sadly, the pregnancy cannot continue. So, what's that critical clinical change that makes it inevitable?
This table is everything. Seriously, burn this into your brain. Look at that last row, the cervical os. In a threatened miscarriage, the cervix is closed. But in an inevitable or incomplete one, it is open. This is the single most important physical finding. If you examine a patient who's bleeding and find that her cervix is open, you know it's an inevitable process.
Now, let's talk about a slightly different picture: a missed miscarriage. In this situation, the fetus has passed away, but it hasn't been expelled from the uterus. The patient might not even have much bleeding or pain. Often, the only clue is that the uterus feels smaller than it should for her dates.
And this is what you might see on an ultrasound in an early miscarriage. This is a classic blighted ovum, or anembryonic pregnancy. See that gestational sac? It's there, but if you look inside, there's no embryo, no fetal pole. This is a definitive finding. So we know the different types. How do we actually confirm our diagnosis? And what do we do about it? Let's walk through the practical management steps. Your diagnostic toolkit is pretty straightforward. First, you do a careful clinical exam, focusing on, you guessed it, the cervical os. Second, you get some basic bloods, check her hemoglobin, and find out her blood type and RH status. And third, the absolute gold standard, a transvaginal ultrasound, or TVS. This gives you a crystal clear picture and tells you for sure if there's a viable fetus with a heartbeat. Okay, so for an inevitable or incomplete miscarriage, you have to be proactive.
The game plan has 3 main goals. 1. Control the bleeding, maybe with medications that make the uterus contract. 2. Replace any blood she's lost with IV fluids or a transfusion. And 3. Gently clear out the uterus, typically with a procedure like a suction evacuation or a DNE, which stands for dilatation and evacuation.
We have covered a ton of ground, so let's boil it all down to the absolute must-know, high-yield points that you need to walk away with. Here are 2 common traps to avoid. First, I'm going to say it again because it's that important. Closed os means threatened. Open os means inevitable. That's your key clinical sign. Second, don't assume the uterine size will match the patient's dates. In a missed miscarriage, for example, the uterus will be smaller than you expect because fetal growth has stopped.
So, what's the #1 cause of early miscarriages? Genetic abnormalities. They account for about half of all cases. And if you want to be extra sharp, the single most common specific problem is trisomy 16. That's a top-tier, high-yield fact.
And if you need a simple way to remember the causes, this little saying is perfect. Early losses are about the seed, the embryo. Later losses are usually about the soil, the maternal environment that supports the pregnancy.
So let's end with a quick thought experiment. Put yourself in the clinic. A patient comes in, she's 10 weeks pregnant, and she's bleeding and has some pain. What are your first steps? What's the one thing you need to check on your exam that will change everything? Think it through, because applying this knowledge is how you truly master it.